Me and three of my friends ran for a bus one day and I just couldn't catch them. They got on the bus, they get off the next stop and they walked back to meet me, to ask me what's wrong with me. I didn't know there was anything wrong with me. But then I went to the Union Chapel and we had a dinner and the van was outside, so I decided to go and have a look. I found out that I was filled up to here with TB. I used to be an athlete and I was very good. And then I couldn't catch a bus.
Working at the Health Protection Agency in London, Ibrahim Abu Bakr and Peter White report their findings in the BMJ on the efficacy of a mobile screening unit for TB.
It is going to be an interesting time.
They're urgently looking for new ways to tackle the return of the disease in our urban areas.
TB has re-emerged in the UK in part because of the increasing rates in particularly vulnerable populations. So people that are deprived in our major cities, such as homeless individuals, people who have history of imprisonment, as well as problem drug users. These groups are living in overcrowded situations, often, are living in settings where their immunity may not be as good as one would want to protect them from infection, and therefore they are particularly vulnerable to acquiring the disease as well as to transmitting it to each other.
Marina Lavelle suffers from multiple health problems.
I'm not allowed sugar, I'm not allowed bread, I'm not allowed sweeties of any kind, so you're not going to stop me smoking. I'm going to smoke. I've been doing it since I was 9 years old.
She doesn't always do what's best for her health, but today she's waiting for London's mobile X-ray unit to find out whether she also has TB.
My boyfriend had TB, but now he's okay because he got tested. I don't know if it was tested by this, but he got tested, and now he's okay. But there's a lot of blokes here live rough and everything, so you know, you never know what they can pick up.
Just after the war, many experts thought that John Crofton's new treatment with streptomycin would eradicate TB once the whole population had been screened.
If they don't get treatment, it will destroy their lungs eventually, which is what happened in Victorian days. People died of consumption, and that'll be the same now.
If you go back even 20 years ago, tuberculosis was considered a disease of the past. Services haven't really evolved to meet the needs of the client groups that it is now affected.
As levels of TB increase again, especially in the UK, is John Crofton's work being undone? There are a number of crucial differences, of course, between the screening methods of the post-war era and the latest digital X-ray technology and methodology.
This intervention is indeed like back to the future, because although you may think that we are reintroducing an intervention that was used 50, 60 years ago, it is very new. The digital X-ray machine is an improvement over the old technology. We are not suggesting that every individual walking around in the population is screened, as was done in the past. And the difference here is we have specific high-risk groups where the rates of TB are so high that it is worthwhile and cost-effective to target and screen them. So although we are using what looks like a very old technology, it is a very new tool and it is cost-effective.
That's the advantage, I think, of this mobile unit, is that we can then access them straight into the local chest clinics and fast-track them in straight away. You know, once they're at that stage, it's, you know, it's pretty serious, so they don't have to wait for appointments. We do have the facility to get them straight in.
Relationships with the local hospitals and chest services and so on, so, you know, we can get them in straight away without worry that we're going to lose people.
Same day. We can screen between 8,000 and 10,000 people a year in London.
The team started by focusing on particular wider groups such as the Bangladeshi community in Tower Hamlets, but they soon found that the most significant target group is the homeless. It can not only be hard to find people, but it's often very difficult to persuade them to be screened once found. Today, the mobile X-ray unit is being moved only 200 yards from one part of East London to another, because patients at the second location would otherwise just not turn up. Staff can find the task very frustrating.
They say to us things like, I don't want to know, I'd rather not know. TB is curable. If you don't get treatment, it's a death sentence. So I find it incredible that we come to their door and still we have trouble getting people to come on. It takes 90 seconds and it doesn't hurt.
Rates of tuberculosis have been increasing in London for almost 2 decades now. We in fact have the highest rates of TB in London than any other Western European capital city.
If you look at particular conurbations in London, there are places that have rates that are comparable to developing parts of the world.
Take a big breath in, breathe in.
What will Marina's scan show?
And breathe away. You sit back down now. Certainly looks all right. I can't see any sign of anything that needs immediate treatment.
Tuberculosis is a fatal disease if not treated, and it's also likely to transmit to many other people because people can remain infectious for long periods of time. That's the saddest part of our work. Too many of the cases in our client group have been diagnosed post-mortem. If you don't look for it, you tend not to find it. The rates of TB in Birmingham are higher, in fact, than in London. Similarly, Manchester has high rates of tuberculosis. Many of our other big cities similarly have a high homeless community and quite a high proportion of people who are engaged in drug treatment services who we could reach with this sort of a service.
What we found was that the service is finding on average 16 cases each year through the screening process, and these are cases that would either have been found later through current standard practice, which is passive case finding, which is waiting for the cases to turn up and seek care for themselves, or some of them, we think, possibly around about a quarter, may not have ever been found via standard passive means because they had been ill for such a long time.
This service is called find and treat. This is the find bit. The treat bit is a huge challenge. Tuberculosis is curable in nearly all cases if the disease is caught early and the organism is sensitive to the drugs we have. But that requires a minimum of 6 months medication just for the fully sensitive, drug-sensitive forms of TB.
I was offered treatment at the UCH hospital. I was on treatment for 1 year and 1 month, and I think I'm okay again. I was on 12 tablets a day 3 times a week.
Researchers for the BMJ paper wanted to know if the service provided by the mobile unit was not just effective, but also cost-effective.
Our analysis found that this intervention was providing the equivalent of 150 additional years of good life in this population. The technical term for that is the QALY, the Quality Adjusted Life Year. In the UK, usually, if the cost is about £20,000 or less per QALY, an intervention will be considered cost-effective. We found in this population the cost of gaining a QALY was between about £6,000 and £10,000. So by the usual standards of the UK, this would be considered very good value for money.
We actually prevent future cases of tuberculosis by finding the disease early. Most of the NHS screening initiatives, cancer screening, nearly every other NHS screening initiative, all the benefit of that screening will be realised within one person.
The analysis that we have done so far has been considering the benefit to the individual patients who are being found and treated. We have not yet been able to incorporate the additional benefit of averting transmission events, which of course benefits the health of the people who don't get infected and saves the NHS money by not having to treat those people. This means that the service will actually be more cost effective than we have been able to calculate so far and could even potentially be cost saving.
The benefits of what we do are manifest for years to come. We prevent future cases of tuberculosis.
It stops the ongoing transmission, doesn't it, to other people?
Using this approach of a mobile van to go to the patients in these hard to reach groups may be a successful approach for dealing with more than just tuberculosis, but also infections that are common in these groups such as hepatitis and HIV. And it may be that combining a service that deals with multiple health problems in one van to reach these groups is an even more cost-effective approach to delivering healthcare.
When the van turn up, try and get on it because it's free coming to your door. Yeah, and it only came around once every 6 months, so if you get a look once every 6 months, take it.
It's like the takeaway of the NHS.
Takeaway.
It saved me, it saved life. And I don't think we could do without it, because TB is a thing that is spreading rapidly.